The spine is an incredibly complex structure that has a myriad of functions, one of which includes protecting the spinal cord, one of our more important neurological structures. But in addition to that protection mechanism or function that it has, it also has the ability to move in all three planes, large ranges of motion contributed by relatively small ranges within each segment. When I look at the spine, we're going to focus today's discussion on the lumbar spine, and there's a couple of things that we need to understand, and one is when we talk about motion, we want to talk about motion segments, and a motion segment is just two corresponding vertebrae with the corresponding disc that is contained between them. So we have motions individually that include flexion, extension, rotation, and any combination of all three motions. And it amazes me when I look at gymnasts that are able to extend their spines so far back that their heads touch the backs of their knees, or when I look at Olympic weightlifters that are able to maintain a position of stability through their spine as they lift 2, 3, 4 times their body weight over their head. It's an amazing structure. So let's take a few minutes and dive in a little bit and start looking at how the skeletal anatomy and the discs function and the individual joints move with the lumbar spine. So here are opportunity to talk about the spine, and we're going to start today with the lumbar spine and take a little closer look at what stabilizes the lumbar spine and what helps, what types of motions we can expect. But before we jump into that, I want to get an idea of really the entire structure, because it is a complex mechanism and it's designed to maintain erect posture and maintain stability of the trunk, while at the same time providing and permitting movement of the head, neck, and head, neck, and trunk. So we have 4 curves in the spine. I have a cervical, a thoracic, a lumbar, and a sacral curve. The cervical includes the 7 cervical vertebrae. Thoracic curve includes the 12 thoracic vertebrae. We can identify those thoracic vertebrae by the fact that ribs attach to them. And 5 lumbar vertebrae followed with the fused sacrum, which are 5 fused sacral vertebrae with 4 fused coccygeal vertebrae. So the primary curves occur at the thoracic and the sacral curve, and if you think about in development, babies are kind of in that fetal position. That thoracic curve and that sacral curve follow that position, and the secondary curves then become the cervical and the lumbar, and we can think of those as secondary curves because they develop postpartum during the developmental sequence of head and neck extension, as babies are lying on their tummies and start to lift their heads to see where they are in space, and then they start pushing themselves up, and as they push themselves up they start to get lumbar extension. So we think of the thoracic and sacral vertebrae as our primary curves, and cervical and lumbar vertebrae as our secondary curves. But we're going to spend today really looking at the lumbar vertebrae, and as we can see, the vertebrae as they move in a caudal direction, they tend to get larger in diameter and in size, and this allows for the mass of the upper body, the head, arms, and trunk, to be transmitted down through the sacrum and into the ilium. So just the weight of the head on the cervical vertebrae is much less than all of the weight of the head, neck, arms, chest on the lumbar vertebrae. So I want to take a look at what what a typical lumbar vertebrae looks like. So here we have our lumbar vertebrae, and if I look at it from the side, we can see the colorations of a variety of different articulations, processes, and bony landmarks that we need to be able to identify. So if we look at posteriorly, I have the spinous process, and the spinous process is an attachment for the latissimus, the interspinalis, multifidi, the parts of the thoracolumbar fascia. So it is a palpable structure directly off the posterior aspect of the spine. If I move in, I have the lamina, and the lamina really makes up the posterior portion of the spinal canal. So there's the spinal canal, there is the lamina on each side. As I continue to move through the direction of the spine, I have the superior articular processes, and if this is L4, then this would be the articular surface with L3, and I have an inferior articular surface, which would be the articulating surface that would articulate with the with L5. The pedicle is the arch that kind of connects the posterior arch of the vertebrae with the body of the vertebrae. So it's this short, thick process which also attaches the transverse processes. The transverse process has a variety of muscle attachments to it, including some muscles that we've learned, and some which we will discover this term. And then lastly, I have the body, and the body of the vertebrae attaches the psoas. We also have a variety of ligaments that attach to it, and the intervertebral fibrocartilage, also known as the disc. So let's take a minute and talk about the articulations and specifically about the articulation between the bodies of the vertebrae, which is a cartilaginous joint and separated by the intervertebral disc. So that is an example of the intervertebral disc between each of the vertebrae. Okay? So the disc is composed of the nucleus pulposus and the annulus fibrosus. And let's take a little closer. Let's kind of zoom in on that a little bit and see if we can see what that looks like there. And as I come down, there is our highlighted disc between the third and the fourth lumbar vertebrae. And what I want to do is take that vertebrae out. So now we have a little bit better picture of the disc. So again, the disc is composed of the nucleus pulposus and the annulus fibrosus. The annulus fibrosus is composed of these concentric rings with a fiber orientation that is perpendicular to each other. So if I spin this up and look a little closer, we can see this fiber orientation where I have some fibers heading this direction and some fibers heading this direction. And if I go and look in the at the deeper layers, if I were to look at these inner concentric rings, the fiber orientation would primarily be perpendicular, vertical. So I have fiber orientation that runs perpendicular at an oblique angle, and I have a fiber orientation that runs vertical. The nucleus pulposus then is composed primarily of water, collagen, and proteoglycans. And the fluid in the proteoglycan concentration is highest in the nucleus pulposus, whereas the collagen content in the annulus fibrosus is highest. So I have a much greater proportion of collagen fibers in the annulus fibrosus, much higher concentration of water and proteoglycan in the nucleus pulposus. And that's kind of an important consideration when I look at really what the function of the disc is, which is to help to transmit forces through the spine. So you can imagine for a minute, as I have a compressive load coming down on this disc, the fluid is going to be forced out. And as that fluid gets forced out, and remember how articular cartilage works, the proteoglycans get closer together, which then becomes stiffer and will resist that motion to a greater extent. When the load decreases, the water flows back in. So while we're resting at night, sleeping, lying down, no compressive load through the spine, the lumbar vertebrae fill with water. And when we wake up in the morning, that's when we tend to be tallest, because if I look at how much the contribution of our height occurs through the intervertebral discs, we recognize that a third of the entire height of the spine is contributed by the height of the discs together. So when we look at people as they age, we notice like, oh, okay, they're getting shorter. They've lost an inch, 2 inches in some cases. And a lot of that has to do with the changes in the architecture of the intervertebral discs, where they start to lose their ability to imbibe water. So they become drier, and as they become drier, they become less mobile, and they lose their height. They lose their concentration of fluid. Now, looking at the fiber orientation of the annulus fibrosus, and again looking at this oblique orientation of the collagen fibers, we can recognize that if I were to rotate, in this case, if I were to rotate to the right, we can see this line of fibers would generate, would resist that motion. But the orientation of the fibers that are going this direction would actually be slackened. So the disc, while it does a great job at providing resistance to motion through compression, it's less stable when we add a rotary component to it. So we do see a decreased ability to withstand load when we go into that rotation component. Now, what about injury? Do our discs ever become injured? And we'll hear about herniated nucleus pulposus, where we may see an injury in the annulus fibrosus and the nucleus pulposus wanting to edge out into this space. Well, the nerve root coming off of the spinal cord exits through that space right over the top of the pedicle. In that space is the intervertebral foramen for the nerve root to exit, and can create an impingement on that space. So if I am here and I have a nerve root coming down, exiting, but now I have this disc bulge coming out, we can see how we can get an impingement, which may affect motor function, may affect sensory function, may transmit pain or weakness down the leg in the lumbar spine, may create impingement on the nerve root as it innervates the rest of the spinal column, and the individual nerve roots innervate 1 to 2 levels above and below. So we could be chasing pain all over the place in the lumbar spine from a disc herniation. So that's the intervertebral disc and how it wants to function in providing compressive resistance and transmitting compressive loads through the lumbar and thoracic cervical spine all the way through. We're going to spend a few minutes talking about the ligaments that support the spine, and we can divide the ligaments up into those that support the vertebral bodies and those that support the vertebral arch. So the first one we want to talk to, we'll just kind of go from the deepest to the most superficial, is the anterior longitudinal ligament. The anterior longitudinal ligament runs the whole length of the anterior surface of the spine. So if we spin this around, we can see that it really covers the bodies and the discs, and is really primarily responsible for checking excessive extension range of motion. So as we go into that back bend direction, we can appreciate the tension load that this ligament is able to resist. So the next one is the posterior longitudinal ligament. If I kind of turn this around a little bit, we can start to see how it runs on the anterior surface of the vertebral column. So it's the posterior surface of the bodies and the discs. So if I take one of these discs and hide it for a second, we can kind of appreciate the posterior longitudinal ligament a little bit better there. And that is responsible for checking flexion range of motion. So it's going to become a little bit more taut with as we move into that flexion range. The anterior longitudinal ligament is about 2 times stronger than the posterior longitudinal ligament. And as we get up into the cervical spine, we'll see how that blends with some stabilizers in the cervical spine, as well as some of the other ligaments that support the vertebral arch. So those are the 2 that are primarily responsible for attaching to the bodies of the vertebrae. Now, we can appreciate a little bit too this orientation of the posterior longitudinal ligament and how it actually expands a little bit out across the surface of the disc. And one of the responsibilities that the posterior longitudinal ligament does provide is some additional compression support on the disc. So typically, if we're going to have a disc herniation, it's going to be a little bit posterior lateral. It's going to want to come in this direction or that direction, and it's going to because it's a little bit more supportive, a little bit stronger through that directly posterior range. So we've talked about what makes up the posterior arch, the pedicles, the lamina, the transverse process, the superior and the inferior articulating surface and spinous process. One of the more important ligaments that provide support to the posterior vertebral arch includes the ligamentum flavum. And the ligamentum flavum, we can see, is on the posterior surface of the vertebral canal. So if I look here, that vertebral column would go through that canal. So we have this ligamentum flavum that is attaches to one level, above and below. And the interesting thing about the ligamentum flavum, and it does provide resistance into flexion, but even as the spine moves into extension, the ligamentum flavum is under constant tension. So even at neutral, there's tension on the ligamentum flavum. So it's a big supporter in providing stability from level to level. The other ligaments that are along the transverse processes include the intertransverse ligaments, and these are going to have increased tension with side bending. Now, if I look at the size of this ligament from transverse process to transverse process, and I say, okay, that's not really all that big, is that really going to be of significant support as I move into a lateral flexion direction? And the reality is probably not. But remember, we have in ligaments a number of proprioceptors that tell us where we are in space. And I think when we look at the value of the intertransverse ligament, then we really see the significance of providing proprioceptive feedback depending on the motion that we're creating. So the supraspinous ligament runs superiorly along the the supraspinous ligament runs longitudinally, lengthwise along the spinous processes, and it runs the entire length and is going to generate tension when we look at flexion direction motions. So this helps to maintain stability between spinous process and spinous process. There is an additional ligament that is not identified, and that's an interspinous ligament. And there's a ligament that runs from the inferior surface of the superior or cranial spinous process and inserts into the cranial surface of the caudal spinous process. So the interspinous ligament runs from spinous process to spinous process between the length of the spinous process. It covers that whole space. An additional ligament that I think is important for us to appreciate is the iliolumbar ligament, and we can see the iliolumbar ligament on from the ilium coming straight across to the fourth and fifth vertebrae. So as I spin this around, we can see that vertebrae. Additionally, we have the sacrotuberous ligament. We have the sacrospinous ligament, the inguinal ligament, all providing strength and stability to the sacrum and the sacroiliac joint. Okay, so those are the ligamentous structures that are responsible for providing those that stability from level to level through the lumbar and the sacroiliac joints. Motions at the spine are really dependent upon the orientation of the facet joints and their relationship with the intervertebral discs. The amount of motion at each segmental level is variable, but it contributes to the overall motion at the spine. What really drives the motion at each level is the spatial orientation of the facet joints. So when I'm looking at the lumbar spine, the facet joints are oriented from a transverse plane. They're almost vertical, so they're about 90 degrees from the transverse plane, looking up almost vertical. And then when I look at relative to the frontal plane, they're about 45 degrees. So they're oriented about 45 degrees in this plane, and they're up vertically about 90 degrees. So what that does is it allows motion to occur that really takes into account the type of joint this is, which is a synovial joint that is a non-axial gliding joint or a plane joint. So if I look at the actual motion, I can see that as I go into flexion, the joints become distracted. They are oriented in such a manner that flexion distracts the joints, whereas coming back into extension, the joints become compressed or become approximated. So flexion gaps the joints and extension closes the joints. Distraction and compression. So when I look at lateral flexion, then I can see that on the contralateral side, I am just going to be gapping those facet joints. They're going to slide up and gap, which would mean that on the ipsilateral side of the lateral flexion, those facet joints are going to compress or approximate. What that means is it creates this concept of a coupled motion, where when I laterally flex to the right and I have right facet joint compression, because of the orientation of the way those joints want to slide down, it will create this coupled motion of left rotation. So anytime I have from a neutral spine position right lateral flexion, I will have left rotation, which would mean on the opposite side, if I have left lateral flexion, I would have right rotation. And that is a function of the orientation of the facet joints on the approximation side, on the side where the facet joints are compressing. So when I look at right rotation as the primary motion, I'm gapping on the rotation side, the ipsilateral side, which would mean I am compressing on the contralateral side. And again, when I have that compression, it goes with the ipsilateral lateral flexion. So right rotation, approximation, right rotation, compression, coupled motion would be right rotation, left lateral flexion. So we're going to finish talking about the trabecular systems. And the trabecular systems correspond to stresses that are placed on the vertebrae. And we can see that we have a vertical, an oblique, and a horizontal trabecular system. And the vertical trabecular system is here, the oblique is here, and the horizontal is here. So the areas where these trabecular systems overlap is an area that is strongest, because those trabecular systems are designed to dissipate forces, to kind of transmit the forces through the bone. So if I have an area where I have multiple trabecular systems, it does a little bit better job at transmitting those forces. The vertical trabecular system is primarily in the body of the vertebrae and is responsible for dissipating compressive forces, whereas the oblique and the horizontal trabecular system is primarily responsible for dissipating shear forces. So where I have an area where there is not an overlap, I have a zone of weakness, and our zone of weakness is then the area anterior, and this is where, if I see a compression fracture in the body of the vertebrae, it's typically in the anterior aspect in this zone of weakness. So that's what we're going to conclude with our initial discussions on the lumbar spine, and next unit we're going to talk a little bit more about the muscular attachments and how the muscular attachments and the fascia influence lumbar support and lumbar motion.